Hello, everybody. This is Amy St. Croix with the Statistics Division. I want to welcome you and thank you for joining us today. Our speaker today is going to be Mr. Tom Pearson, who is a data analysis. He's a data analyst, an ASQ fellow, and a Six Sigma Master Black Belt at Franciscan St. Francis Hospital in Indianapolis, Indiana. Tom has a master's degree in operations research from the George Washington University in Washington, D.C., and he also specializes in systems innovation and improvement with experience in aerospace, defense, automotive, electronics, pharmaceuticals, and healthcare. Today, Tom will be talking with us about how breakthrough innovations and improvement in healthcare depend upon systems thinking and statistical engineering. Throughout the webinar, all phones and microphones other than mine and Tom's have been muted. So if you do have any questions or comments, we do encourage those. During the webinar, please use the questions interface in the GoToMeeting control panel. So at any time, if you have a comment about a particular slide or a question, please use that, and I'll communicate those thoughts and questions to Tom. So at this time, I'm going to hand things over to you, Tom, and we thank you again so much for presenting with us.
Well, thank you, Amy. It's great to, let me click my screen here. Do you see me?
Yes.
Okay, good. All right. Thank you all for joining us this afternoon. It takes a great deal of dedication to join us at 4 o'clock on Friday afternoon. I appreciate it. And as Amy said, one thing I'd like to try today is if you have questions or comments, if we can make it a little more interactive than the typical webinar, we'll try to work those in sort of on the fly as we go. So please use the chat feature whenever you get a chance or you have a question or a comment, and we'll try to include those. Here in a sort of a nutshell is the message that I'm trying to give, and that is healthcare improvement, especially the discontinuous radical healthcare improvements that we're after, are a fairly complex function of the information sciences, innovation, statistical engineering, systems engineering, a lot of technology actually. And this is a little bit different than what we've seen so far, and it's just beginning to be recognized and appear in the literature. You'll see references periodically in this presentation to papers and presentations that are important efforts or important contributions in this area. But my background is fairly diverse. Some people say I can't hold a job, but actually it's not that so much as I've just been at it a really long time. I started out doing aerospace and defense with the Navy, moved into the software business doing quality-oriented software for manufacturing, up through automotive, electronics, discrete manufacturing, on into process industries and pharmaceuticals, and now into healthcare. And the amazing thing to me, and I've written about it and talked about it some, is that the life cycles of these industries all have some significant similarities. Turns out we start out looking at things and saying, oh gee, this is so complicated, we can't automate this. This requires more art than science. And then we go through a period of time where we realize that, oh my gosh, we do have to record data. We do have to be responsible and report. And then we realize, gee, if we're not using that data to make things better, we're going to fall behind. And so we'll talk a little bit about that. If you look at this, as Amy said, my background is football and physics in undergraduate, and then on to operations research in graduate school, and then into the software business. And I've probably been more of a systems engineer, systems designer than statistician, certainly. So, but I'm a long-time fan of statistical methods and have been interested forever and have used them and always had some good statisticians to work with, and that kind of teamwork is what I'm really sort of hoping for here. Let me start out with just the obligatory case study, and I won't spend very much time on this. Franciscan St. Francis Health in Indianapolis is a brand new hospital, started in '96, finished in 2012. If you look at this picture, this area here to the right, over in here, is the newest part, and it's 440 some inpatient beds. The emergency room size was doubled up to approximately 70 beds. It's about 80,000 visits a year, inpatient or emergency room, and maybe 100,000 inpatients a year. So good size hospital, one of 14 hospitals in the Franciscan Alliance, and has been one of the larger corporations in the Indianapolis area. We're going to talk a little bit about a problem that was a really big deal 3 or 4 years ago, and I want to use that to highlight one of the issues that we really face. 3 years ago, everyone in healthcare was talking about imperatives to provide more care, better, faster, at lower cost. But it's turned out that the target that we're shooting at is ever changing. And my first example of that is when we first started looking at the emergency room at the new St. Francis Hospital, we were looking at about 85,000 visits a year. Those visits were increasing. We didn't have enough bed space, and so that caused us to build the new emergency room. And in the process, we were trying to predict how many patients we would have when we closed a nearby hospital that was 100 years old and moved everybody to the new hospital. So there we were trying to do prediction. And it's amazing what kind of predictions you get. We had people in marketing who were standing around saying things like, oh, gee, we expect a 3% increase per year. We had people in the business side who looked at things and said, well, we've done a straight line projection and we expect it to be stable. And of course, as you probably realize, none of those things turned out to be true. We actually have had a little bit lower attendance in the emergency room and the inpatient area since the onset of Obamacare. So, in any case, prediction turned out to be one of the areas where it's going to be most important for us to get better. And when I look at how well we do with things like predicting weather, I think, gee, we've got the technology, but we just haven't figured out how to apply it to something as important as healthcare. Meanwhile, the other thing that happens here is all of the technology vendors of the world the IBMs and the SAPs and all of the big technology vendors have already long since figured out that healthcare is the next big thing. So they're all offering solutions that will solve all of your problems as long as you give them an unlimited check. So we also know that from experience in other industries that hasn't worked very well in the past. Finally, one of the areas that has come up recently, and you'll see a reference to that later, is that when it comes to innovation and improvement, and statistical engineering is now an area where we're saying it's extremely important that we learn to deal with multiple variables and complex fits and predictions, and try to really understand what a root cause is, and maybe even get to the place where we realize that just asking why 5 times isn't really going to get you to a true root cause. Anyway, the emergency room, at the time we started, we didn't have enough capacity. Demand was increasing. Payments were bound to decrease. We found that in many cases the emergency room filled up because during the day the inpatient rooms filled up and there was no place to discharge a person from the emergency room and to a bed on one of the floors. And so things backed up through the system, and pretty soon the emergency room came to a standstill. We looked at saying, well, let's build more beds, and it turns out that $1 million a room is probably a fairly conservative estimate for how much it costs to build another emergency room, not a patient room in the emergency department. So, you know, to avoid the long waits for arriving patients to see the doctor, we had to figure out smarter ways to do this, and there's all kinds of reasons in terms of the safety for the patients and the customer satisfaction for patients and loss of revenue to the hospital about patients who leave without being treated. So we looked at some objectives and we looked around, and hospitals and healthcare have always been really big on best practice. And so we looked all over the country. We had people looking at things and saying, gee, we want to be able to improve patient satisfaction, improve patient safety, reduce the time it takes for a patient to see the doctor, reduce the length of stay. You'll see LOS here and there. LOS almost always refers to length of stay by 30%. And create capacity for what we anticipated to be an expanding census. So among the other things that we tried to achieve was realizing that a fair amount, maybe a little over half of the patients who were coming to the emergency room did not require a bed. They were mobile, they were vertical, they were ambulatory, and it was better to keep them ambulatory and keep them moving and move them through almost an assembly line because when you do that, you dramatically increase the number of patients that can be seen with any given number of emergency rooms. So, in any case, we were looking to find, exploit, remove bottlenecks in that process, and it was interesting that one of the doctors who was the head of one of the leaders of our Six Sigma team to work on this problem became a huge fan of Henry Ford and the assembly line and began to talk about assembly line processes in a very knowledgeable way very quickly. As we pursued the project, we looked at the resources, and one of the things that had happened is like most hospitals, most larger hospitals, we had the electronic medical record system installed going online, and so we not only had lots of data about particular patients and their condition and their treatment, but we had lots of logistic data about where they were, how long they were there, how long it took, what in general did that kind of patient need. And so in addition to having data that was very controlled with respect to HIPAA regulations, and we couldn't actually publish it, we had lots of other data that was perfect for looking at doing predictive analysis in terms of how well the process was working and how well we could make it better. We also did a little bit of discrete event simulation to test the number of servers and try to find a happy medium where we were serving people promptly and not having them become upset and leaving without being seen, or we have even had a few, from time to time, we have a few that leave during treatment against medical advice. But we kept those numbers down, and the end results of all of this were extremely valuable in helping guide the improvement team when they had an idea about how they might improve patient flow, for example. We could test that idea with some of the models, or go back and look at some of the past data and say, no, that turns out maybe that one wasn't the case. And we know that anecdotally it seems like it's true, and you get a lot of complaints, but gee, it's only happening a very small fraction of the time.
Hey, Tom.
So, yes.
Sorry to interrupt, but we do have a question.
Okay.
Somebody's asking what software you used for the simulation.
Well, it's not. I'm not advertising software. I will tell you that we used a rather low-level piece of software. It wasn't the expensive software. It was very good software. It was, I'm going to have to be careful now and say it right because I'll say it wrong. It was MedModel from ProModel. And we liked that because it was fairly simple to use and it didn't cost a lot and to get started. There are several classes of software. If you're going to do that, I would suggest you might want to look at the ProModel.com website, because they've got some really good stuff on their website that illustrates how that can be used. And there's a little more about that as I go along. Just to wrap up the case study, our first year's results after 1 year after the study, our patient satisfaction had improved from the 13th to the 75th percentile. They like to say that our ED has become the rock stars of the hospital because our patient satisfaction is up, our length of stay is down 16%. The median length of stay for admitted patients increased or decreased by almost 7%. You can see several of these here. If you look down, you'll see the bed turns went up about 25%. And that's because half of the patients were being moved through a series of rooms rather than being parked one patient in a room, and that worked out very well. Let's see. And I guess the last thing here is that as we moved, we did not see the volume increase that we expected in the new ER, but we did see a very significant increase in the number of inpatient admissions from the ER to inpatient status, because we believe it's because we were seeing higher acuity patients. So from that, we learned a couple things. Number one, we learned that you really need to apply good statistical methods to your analysis. And we primarily used Lean Six Sigma techniques to do this. But when we first started Lean Six Sigma, we had a little bit, and this is not unusual, you find lots of low-hanging fruit and things you can improve with the introductory level lean kind of concepts, but at the further you go, the harder it gets, and you ultimately end up at a point where the more sophisticated analysis of more variables simultaneously are necessary to really make the improvements, and especially the discontinuous leaps that you hope to make. And I got a couple examples of that in a minute. In the process, I came across this wonderful quote by Albert Einstein that really summarizes exactly what I'm trying to say. Computers are incredibly fast, accurate, and stupid. I also sometimes say be careful, they'll do exactly what you tell them. Also, human beings are incredibly slow, inaccurate, and brilliant. However, when you put them together, they are really powerful. And this enhanced man-machine partnership has been something that has intrigued me, for years, from the early days in management in aerospace all the way through to the current day. So the real question in my mind is, how do we use the new technology more effectively in order to solve more complicated problems and make bigger improvement leaps? One thing that we learn, and it's been taught over and over again, is that when you think about Six Sigma, that DMAIC is not a linear process. It's an iterative process. And you may start out defining your problem and trying to measure, and somewhere between measure and analyze you find things that need to be added to your definition, and so you have to jump back for a minute, and then when you get to improve you find something else you need to remeasure, and so it's valuable to think about Lean Six Sigma as being an iterative process that sort of branches back and forth. And this particular slide comes out of a presentation I made a couple years ago where I was talking about 7 super tools. And think of the basic quality, the 7 basic tools of quality and the 7 management tools. And you might, and I was, a little bit of my marketing background slipped through here, and I started talking about 7 super tools. But you might think of this as the 7 power tools from the innovation or the information. Now I'm going to jump ahead a little bit to the present day and talk about the President's Council on Science and Technology, or PCAST. This is a group that meets about quarterly to advise the President on how technology impacts important issues, and in this case healthcare. In fact, this particular information is available on the White House website. If I go here, I can click. I'm not sure you can't do. I don't think you can do that on the version that you have. But if you need that reference, let me know and I will get it to you. By the way, my phone number and my email are both on that introductory slide that had my little cartoon picture and that kind of thing. But in any case, this message of this report basically was that real improvement in healthcare requires more innovation and innovative systems engineering applications to reach the required levels of breakthrough kind of improvement. Along those lines, Intermountain Health is in Utah is sort of the poster child for doing this kind of thing right. And if you want to know about what's possible in terms of statistical methods and statistical engineering as applied to healthcare, Google Intermountain Health. They're tremendous examples. And if you look at this, in particular, if you look at the bullets down below, Intermountain was one of the first hospitals, among the first, to recognize how important electronic health records were, and they deployed their first one in 1972. During the time that they were doing this, the Institute for Healthcare Delivery became analytics to fuel healthcare innovation. Recently, the president recognized Intermountain as one of 3 specific examples that consistently delivered high quality at low cost, and a recent study by Dartmouth Atlas suggested hospitals could lower their spending by 43% if they could use the Intermountain Health benchmark or achieve the Intermountain Health benchmark. All of us in the field want to, partially because when you walk out the door you see purple mountains with snow on them. But it's a very, very successful operation that they've done, and they offer lots of good information. Their website also is extremely valuable. Okay, so now let's talk about those 7 tools. And I want to talk about systems thinking just a little differently, maybe, because my background included not only operations research, but also a stint as an entrepreneur and a software designer and then a software executive. And what I really wanted to say here was, and for years I've talked about the requirement to balance 3 separate spheres of influence, and if you let any particular one of those get out of whack or get too big, you reduce the overall value. What you need to do is align them, and if you could bring them all into perfect alignment, then that success area in the middle, it's represented here as intellectual capital, but it could be savings, it could be profit, it could be improvement, but it's whatever your target value is. Then if you brought them all together, then that would be maximized. And I like to talk about the business issues, the technology issues, and the people issues. And when you look at the business issues, I like the little acronym for CEO that basically says you're trying to satisfy your customers, your employees, and your owners. And if you can do that consistently, you're going to have a good business for a long time. But if you shortchange any one of them, it won't last very long. And so the business systems are very, very important. And this is an area where healthcare has been dominated almost exclusively by the finance and accounting side. And because of that, it's been sub-optimized in my experience. If you look down on the people side, then there you're looking at the things that you have to actually do in order to run the business. And healthcare is one of those places, as a service industry, it's a place where the employees are in contact and make the delivery to the patient. And so it's very important that you keep everybody aligned. Finally, when you look over the technology area, there's questions about, well, how do I do that? And those abbreviations there stand for business information, data warehouse, data mining, predictive analytics, simulation, and systems engineering. And what I'm trying to get to here is that if we think in terms of all of those areas, we stand a better chance of actually improving the output and coming up with the significant breakthrough improvements that we're looking for. And one simple example of that is the sweet spot for length of stay. We started out saying we want to reduce length of stay. But of course you don't want to reduce it too far, because if you reduce length of stay too far, then people have complications and they have to come back to the hospital. They may not be completely cured, they come back. And the way the world works now, if they come back for the same cause within 30 days, the hospital doesn't get paid. And so the other thing is, when you try to reduce readmissions, there's a trade-off between readmissions and length of stay. There's also a trade-off between length of stay and customer satisfaction. We rate very, very highly the whole concept of customer satisfaction, and we try to measure that with things like Press Ganey surveys. The problem with doing that is that again, the things that have been shown to improve customer satisfaction are the same things that increase length of stay rather than decrease it, and also increase the amount of time the staff spends with patients rather than decrease that. And one of the things we're always trying to reduce or improve is productivity, or in other words, reduce the number of staff hours required per patient visit. So you can begin to see that this is complicated, and there's many, many variables. Every patient that walks in the door has a different background, has different symptoms, may have a different diagnosis, and now we're trying to put together a system to help us figure out how to do that whole job better, more efficiently, with lower risk, etc. There was a recent statistical engineering article by Roger Hurl in 2013 that talked about keys to systems thinking, and he talked about data quality, statistical studies, and subject matter knowledge. Now, those of us with a little bit of statistics in our blood are quite comfy with the first two, and I think almost all of us understand the issue that subject matter knowledge is critical. But not everybody involved with Six Sigma understands that, or maybe they don't understand it in great depth. I just thought it was interesting that Roger thought it was important enough to make it one of his 3 critical factors that says if you're going to do this, you have to have doctors, you have to have nurses, you have to have administrators, you have to have managers. And so the idea of an improvement team, whether it's for innovation or Six Sigma kind of improvement, which are very similar and probably ought to be the same thing, you got to have both. You got to have all 3. So the goal is systems improvement, and you can see some examples here that I think I've talked about all of them already, and again highlighting the complexity of the modern ED. Now, and the complexity of the modern emergency department is probably pales by comparison to the complexity of the total hospital, where the emergency department is just one of the primary portals. By the time you look at all of the other departments, it becomes much, much more complicated. So in some respects, trying to decide how long it's going to take for people to be served effectively, how many people will show up on Tuesday, on a normal Tuesday, in the afternoon, versus how many show up on an abnormal Tuesday, that's the day after Labor Day. It's roughly, I think, equivalent to the same complexity of trying to decide what's the weather going to do. And the good news is we've made a tremendous strides in terms of forecasting the weather. But management is all about forecasting, and we need to be able to forecast much better when the surges are coming, how big will they be, what kind of surges will they be, is it because of flu, is it because of some other some weather-related problem or some society kind of thing, or because your competitor opened a new hospital only a mile away, or there's so many things that can happen, and the options there are really important. I like to talk about focusing on the white spaces or attacking the white spaces. And this slide refers at the bottom to an article that I wrote for the Quality Management Forum in, I think it was February of this year. And the whole point here is that every time you cross either an organizational level in the hospital or a silo, like from the emergency room to lab to the labs to radiology to surgery, every time you do that, you're crossing the white spaces, and things have a chance to get lost. They have a chance to get confused. They have a chance to get delayed. You know, it's just been classic. And what we are finding is, what I found in my approximately 10 years working in healthcare, is that almost every delay or place where healthcare bogs down, it's because some piece of information bogged down somewhere. You know, the doctor put in the discharge orders, but it got bogged down someplace, and they're not ready to discharge that patient on time. And so, you know, the complex scheduling and sequencing that needs to go on becomes very, very much like scheduling in high-volume manufacturing, for example. So focusing on the white spaces is a really important area, and we'll talk about that here. There is a wonderful case study from Mercy St. Vincent's Medical Center in Toledo, where Dr. Andrabi talked about focusing on white spaces to improve patient throughput. And this one is important because they spent a couple of years and about $7 million making some systems improvement, and they saved $73 million. So if you're going to make big changes like Intermountain Health, or if you want to make big improvements like Mercy St. Vincent, now we're talking about something that is more than a 5S exercise. We're talking about something that involves systems engineering and statistical analysis, and you know, where the odds are much higher, or where the stakes are much higher, and you've got to pay more attention. And along those lines, I'm only going to mention this very quickly. One of the things that we've started looking at is predictive analytics and the cross-industry standard process for data mining. And this is too complicated to go into here, but I reproduced it here because you'll have a chance to look at it if you're interested. But the whole data mining cycle, and some of you may be involved with data mining. I would love if you would go to your chat area and just say yes or no, you know, and just chat that, and maybe I can get Amy to count them up for me. But if we can do that, let me tell you why I think it's so important. If you look at the data mining life cycle, and the whole idea of data mining is a little different than what we normally think of. It's certainly not hypothesis testing. It's certainly not you know, trying to establish proof beyond a shadow of a doubt for a compliance purpose. But it is trying to understand, of all of the thousands of things that could be related, and all of the millions of potential correlations that might be out there, which ones are the strongest ones and which ones might be causes and which ones might be effects. And that's something that we're looking for. And so if you look at this basic map of the CRISP-DM method, overlay on that the, here are some of the multidisciplinary team roles, and if you now overlay on that the DMAIC method, what you see is they line up almost perfectly. And not only that, but if you overlay on that the improvement methods or the innovation methods, and I specifically have been a long-time student of the de Bono techniques for innovation, what you find is that those overlay also. And so when you talk about how do we be more innovative, how do we find bigger improvements, how do we find these key relationships in this mountain of data? Remember that we talked about how much data there is coming out of the electronic medical record, which is related and can be used for this process sort of in total without getting involved at all with any of the HIPAA rules for disclosing or identifying information with patients. So this is a whole area where I think this is the simple area where I think what we're going to find is that 10 years from now there will be people that have made the same kind of advances in this as we've made perhaps with trying to understand global weather patterns. So this one is, I think, is one of the most fertile grounds for us to really involve. Now, most hospitals, including our hospital, have a hospital informatics group who are really good at getting data out of our business, our data warehouses and our business information systems, and the data mining tools in many cases can help get that data from multiple sources and clean and cleanse and reorganize and sometimes rebuild that data into the kind of records that we want. A specific example is we have data on the time a patient comes to the emergency room, what their length of stay is in minutes, and then a number of minutes from one step to another. But if we want to go back and say, well, how long was it between the time the doctor said, okay, discharge this patient, until the patient actually was discharged, you have to go do some calculations. And there's 2 or 3 ways to get there. And in fact, you really need to look at it each of those ways and say, okay, how accurate are they? Are there outliers here? What happened? Well, in some cases, it didn't get entered, and so they entered all 3 of the timestamps at the end. And so it looks like it took 0 time. So you have to do some cleansing. You have to do some constructing. And you can, but if you do that right, you can build a tremendous data resource. And the hospital informatics guys are extremely good at this. Yeah, okay. I think we talked about that. There's another area here where I was always a big fan of exploratory analysis and John Tukey. And there's an element of that in this kind of thing too. What we really want to do here is to go back and look at certain data, the data from populations, fairly large populations, and say which ones of these parameters or variables are related to which other ones. Are they correlated? Are they causal? Are they a direct effect? Are they, or is it just happenstance? And so the use of exploratory analysis has turned out to be very powerful We made great strides in pharmaceuticals using these tools. And what we did was we took all of our process data and we would typically develop it in, divide some of the data into two subsets. For example, we might say, what are the difference between really high yield lots and low yield lots? Or in this case, we might say between, short lengths of stay with good outcomes versus longer lengths of stay and lesser outcomes. And then you go through and do some comparison and contrast. And the modeling can be statistical, sometimes it's mathematical. When it gets to be a little too complicated in the terms of the time frame, we may use the discrete event methods, the simulation methods. By the way, one thing interesting about this particular thing is, we talked for years about looking at data in frequency domain or looking at distributional analysis versus looking at data in time domain, which might very well be correlation, autocorrelation, predictive models, that kind of thing. In this kind of analysis here for exploratory analysis, one of the neatest tricks that you can do is to reorganize the data out of its time sequence and into a product sequence. In other words, in the pharmaceutical area, what we did was we took lots and lots of detailed data about each lot of product that ultimately made its way through the process and was finally analyzed, and reorganized it so that the cases that we were looking at were the lot numbers. In other words, we had things that happened across the process at different times, but all tied to the appropriate lot number, so that when we got done, we could say, well, lot A turned out to be much better than lot B. Why? And that particular trick has turned out to be very, very powerful. Okay. And you don't even have to use sophisticated statistics to do some of this. Once you have the lots separated, we made a lot of progress just using very simple things like control charts or histograms. And again, remember, Tukey was a big fan of simple graphics, and Tufte's concept of small multiples that says, gee, if you set this up using the same tool to look at many different comparisons, the human can make very, very powerful leaps of consciousness without having to do all of the mathematics. Predictive analytics is the newest thing on the horizon. We've talked about predictive analytics a little bit. It's very powerful. It's coming fast. It's coming hard, and I think we're going to be able to use this. We're doing some very trivial case kinds of things now that says which patients, when they walk in the door, are most likely to be readmitted. But there's so much more that we could do, and that ultimately I think we will do, that says which patients are likely to be readmitted or have complications or require more treatment, or all of those things. And as I said earlier, management is about prediction, and we need to be able to make better prediction. The problem that we have is that all of the easy problems have pretty much been addressed, and now we're left with lots of hard ones. And so it may take a little better application of the technology to streamline operations and target our resources better and that kind of thing. We're not doing a real good job of that yet. This study mentions that organizations have struggled to add information and analytics to the necessary data provided by EHR This is one of the, and this is on here primarily so that you'll have this reference here at the bottom. That's an inextensive study, but it's got lots of good information. I'm not going to say too much about this. This is one of the tools we use to look at the daily forecast or the daily census coming into what we call the now ER, which was the part of the ER where people stayed upright and mobile and moved through. They were the low acuity patients who could move through much more quickly. And we used the blue dots. Well, let me start. Yeah, the blue dots are the individual daily census. So you can see that we had days where we had 82 or 3 or 4, and we had days where we had almost 170. And what you don't see here is you don't see that there is not only daily noise, but there are day-of-week trends, there are hour-day trends, there are about 4 or 5 trends superimposed on top of one another, including ones that if you go off here in fact they don't show on this chart so much, but you'll find places where there's a flu epidemic and it goes way up for a little while. So the predictive problem really becomes an interesting one, and this is a simple exponentially weighted moving average, which doesn't do too bad a job of telling you whether or not overall it's going down or going back up. But we're still looking at some simple ways to convey that to departmental management in the emergency department, for example. Here is sort of a simple example of that, the process simulator software we talked about. It turns out, interestingly enough, that you can end up getting a huge amount of data out of these simulations and run real analysis on them. And every one of these processes gets instrumented with, how many doctors, how many nurses, how long does it take to move people around, how many patients come in by hour of day and day of week, and it goes on and on and on. But when you get all done, what we found is we found some bottlenecks, we found some things to fix, and when we got all done, we were able to transition to the new emergency department model. We turned off the old model and the second old hospital on the same day and moved into the new one without any major disruption, which is a pretty amazing thing. And these guys are on here just for sort of fun, that says we've got to find better interfaces so that when people talk to computers and computers talk to people, that we do a better job. And you don't have to go much further than Google inquiries, for example. In the early days, you had to almost know programming language to ask a question on the web. And now you can ask a question any way you want to, and Google very well may come back and say, did you mean, and ask you whether or not they'd understand you. So those kinds of things. Now, the other thing I think is going to be real important, and especially for the forecasting and for the complex correlation, is some of the visual analytics and animation. And we're not very far along on that, but we ought to be. So the natural interfaces are important. Knowledge management, I think, is real important. And all I want to say about, and there's all kinds of knowledge management tools, but my real question is, where do we build the knowledge management? And again, this is an old slide. You see, this was published first in 1999. And it still sort of remains. It's been updated by changing this one loop to DMAIC, this loop here. So in any case, this is sort of built around the concept of the profound knowledge model, and how do we build new knowledge from data that we collect as we go. And that can be really useful. And again, this paper was written about manufacturing, but all of the concepts still apply. The last one I want to, yes.
Sorry to interrupt. I just wanted to let you know we got about 5 minutes.
Okay, I'm closing up here. Thanks. The last thing I wanted to really talk about was something I call real-time analytics, and that is processes that monitor real-time data flow and tell managers when a process changes significantly. And as you probably have figured out, it uses some automated statistical process control methods. It looks at processes, monitors all of them all of the time, and comes back with real-time alerts and says the number of patients coming to the ED on this Tuesday morning are less than we expected. You may be in for a light day. Or maybe it's the other way, a heavy day. So there's a real-time piece of this, and this is something that they're very interested in, and that is, how do we know this morning whether or not we need more, less, or the same staff this afternoon, or this evening, or tomorrow? And so I think this is going to become very important. It became a staple of manufacturing. And I have the U.S. patent on the wall behind me for a simple way to do this with computers. It's expired now, so if anybody's interested, I'll be glad to tell you all about it. But the second piece is, this is the piece that tracks data and takes, the first piece took data by process to decide whether the process was changing. The second piece collects data by product, a piece of product, or in this case patient, and tracks that to decide whether or not the net result for that patient is good or bad or better or worse. And the last piece is the predictive analytics piece that can look at things and say, okay, given all of that, is there a better way to do our scheduling or our staffing or our, apply our resources? Okay. All right, we've talked about benefits up one side and down the other. I wanted to do one thing here that I've used locally that I think is very important, and that is when you look at the traditional way to do a big DMAIC project, a big Six Sigma project, it may very well take 12 months to 18 months to get it done. It took a little more than 18 months to do the project for the emergency room, and much of that is because you can't get at the data. We spend a huge amount of time trying to get the data. Now with predictive analytics and data mining, we can get data much more quickly, and we can reduce that period of time it takes significantly, so we can do bigger projects more completely in less time. There's a couple of quotes from Intermountain. They say what obviously I put them in there so they back up what I've been saying, that says if you're going to do this, a lot of this is about using innovation and technology and statistical methods more effectively. Okay, so I'm done. Do we have any more questions, Amy?
Okay. Actually, we're running short on our time here, but if you could take one quick question and then we can wrap everything up. Somebody saying that earlier in the presentation you mentioned that you had targets and goals, and he's wondering how these targets and goals were derived.
Oh, wow. No, I can't answer that quickly. It's a pet peeve. It's a pet peeve. Danger, warning. If you, excuse me, I didn't mean to do that. If you are not careful, Goals typically are established arbitrarily. Somebody will go out and say, what's the best in class for length of stay? Or what's the best in class for hours per patient visit? 2.7 hours of staff time per patient visit. When you do that, you're not taking into account the differences between hospitals, the difference between patient populations, the difference between facilities. And if you're not careful, if you establish arbitrary goals, and even if you establish a rather sophisticated method of collecting and presenting the data, you got to be careful you don't end up with the VA. I'm sorry, I shouldn't say that, but I just did. You got to be really careful. You need to understand what those measures are and what the uncertainty of those measures are, and what the relationship between a particular measure and what you really want. And unfortunately, so much of the time, the thing that you set out to measure looks an awful lot something like something you can measure, and you're assuming that that'll get you to where you want to be, and it may very well not do that. So I guess my whole thing about goals and objectives is, I'm not a fan of management by objectives. I'm a fan of understanding the relationship between all those variables and somehow writing the right object function for your optimization problem.
Okay, excellent. Well, thank you so much for taking that question, and thanks again, Tom, for taking the time to present with us today. A recording of this webinar will be available within a few days on the division's YouTube channel, which is youtube.com/ASQ-STATS-Division. So please be sure to check out this webinar and share it with friends, coworkers, colleagues. I'll also be, Tom has been generous enough to provide us with a PDF version of his slides, which I will send to all the attendees by midweek of next week. So be looking out for those. That has all of Tom's contact information on it, as he mentioned. We also encourage you guys to check out the division's LinkedIn page, as well as our events calendar, which can be viewed at asq.org/statistics for all the latest news on webinars, conferences, and many other topics as well. So that's all the time that we have for today, but I thank everyone for joining us, and thank you again, Tom, and I hope everyone has a great weekend. And Tom, you're getting a lot of accolades here. Everyone's saying thank you so much. Very informative, excellent, well presented. Okay. All right, thank you.